17 minutes before the dog starts barking, okay?
Okay. Let's make sure this kind of works. All right, I'll thank the organizers for having me today. I can see from the agenda most of the discussions here are about the omic molecules, proteins, and genes, but there's another whole scheme of molecules, metabolomics, metabolites, that also can be measured, and the talk today focuses on those. Let's see, how do we focus? Just one quick slide about the company. That we've been around for about 12 years. We do measure metabolomics, metabolites, using various different types of CEMS and LCMS-based technologies. We do quantitative analysis and flux analysis as well. So doing the process, and this has probably been talked about yesterday and a little bit this morning as well, there is a whole process that has to go through. So what I'll tell you today is a little story about how we're developing through this process for a marker for multiple depressive disorder. Again, starts with profiling. In this case, we're looking for metabolites using LC and CE-based screening, looking at serum or plasma. Identification, we have a large library, but we also see unknowns. And if those show significance, they need to be identified. There's a validation process where we validate the platform itself, but also validate through larger patient populations. And then there's understanding the biology, why certain metabolites may or may not be increased or decreased in relation to this disease. And then a clinical plan, how that marker might be used in the clinic. We have a pipeline in the company, and what I'll talk about today is the first one here. That's the most advanced on multiple depression diagnosis disease. I'll talk a little bit at the end if I have time about diabetic neuropathy as well. Depression is a major disease in our country. Over 100 million individuals are diagnosed each year with it. There's various treatments for this. There's also misdiagnosis. It's not as easy as getting an MRI scan looking for lesions for multiple sclerosis. It's more difficult sometimes to diagnose and to treat. We have a patent information I'm talking about today, but there is this isn't really working, but there are some patents that we have published on this. For this discovery, we started out looking at plasma from our small cohorts, which I'll describe in a minute. We have SLPs for collecting the blood. Stirring it, it's a liquid extraction, looking at the aqueous layers and using CEMS, TOF-MS to look at for the metabolites. If we compare over 500 metabolites that were in all the samples, looking for association with the disease. The method itself is basically you take your serum, you add 2 internal standards prior to extraction. After you extract and lyophilize, you add 3 more internal standards, and we're using about 50 microliters of plasma. The early discovery, as most discovery starts out with, are for small cohorts. In this case, 30. This is really working very well. 31 healthy, or maybe you just read it. 31 healthy, 34 with major depressive disorder, and 7 others I'll describe in a little bit. The diagnosis is done primarily through something called a CES score, where a score is over a certain level, over 17, becomes then someone can be diagnosed as depressive. So you see the scores in the bottom and the ranges for each study population. So the initial result on the left is a hierarchical clustering or a heat map. These are all relative measurements. From this, we picked out one metabolite which we identified as PEA, phosphoethanolamine. Once we identified this, we went back and made up a quantitative assay. So on the far right, that's let me look at it. This is a concentration on the left and micromolar concentration. And we reevaluated each of the patients once again. On the far left, you have the controls. In the middle is the major depressive disorder, 34 patients, and on the right, adjustment disorder. And there's a significant difference in the median between the controls and the patient target population. The highlighted there as those outliers are really patients that were at the time, though they were diagnosed with depression out of season. These are seasonal depressed patients. The ROC for the single molecule is very good, just comparing the 34 depressive patients with the non-depression stations. Comparing the PEA levels on the left with the CES score, you get a very good correlation. On the bottom right in the red, you can see the majority of the diagnosed patients. On the far left, under the score of 17 or 18 are the normal population. In the purple, you have other diagnoses. We went ahead then and looked at another, that was about 70 patients. We looked at another 100, so this is another data set. We get very similar results. So in this data set, well, I'll show on the blue is the healthy to the left. This is look at the HAM score, which is another criteria for depression diagnosis. And so there, 7 is the cutoff. And if you look at on the far bottom right, you see the depressive patients have low PEA scores or levels. Another seasonal depressed patient is marked on the red. Also in this, these cohorts, we had patients that had been diagnosed as having partial remission and full remission, but also we had bipolar patients in here as well. And what I'll mention later, if I get this to really work, you can't really see well, but there's some patients in here that are bipolar, and with the bipolar patients, during the depressive phase, they have low PEA levels. In the manic phase, they had high levels. The next slide shows clearly the correlation with remission. So in the bottom left are the patients that are diagnosed as depressed and with the low PEA scores or PEA levels under 1.5 micromolar. The next is a partial remission, and finally complete remission based on their CES and HAM scores, and that correlates very well with the healthy population and the other population. So we see is that we see a good correlation with the HAM and CES scores. The PEA levels are restored with remission. This gets back to starting to discuss how this might be used in a diagnostic setting. So the suggestion might be that if PEA scores are restored over 1.8 micromolar, that some of these drugs have significant side effects, so perhaps that medication can be reduced when measuring the PEA level. There are patients with higher PEA level that might suggest other diagnoses, and we noticed that in bipolar disease, PEA is low when depressed, high when manic. When we go and develop this, so we realized that CEMS may not be the best method for a clinical lab or a central laboratory. So I already mentioned that we went from the relative data to a qualitative data by going to a triple quad, but to go to more amendable technology, we went to an ion chromatography fluorescent method, which is more amendable to more core laboratories and high throughput testing. At this point, we've looked at over 1,000 patients, and I'll try once again to get this to work. But oh, here we go. So this is our major depressant. Over 350 patients have been looked at so far with PEA levels under 1.5. The one just to the left of that, I don't know if this is still working, is at this point. These are over 90 patients with partial remission, another cohort of people that are on full remission. And if you go to the far right, the one with the biggest arrow bars are the bipolar patients. And the one next to that is about 300 people with anxiety, which is another common ailment that's often misdiagnosed. And at this point, we're going to even larger studies and looking at a number of different potential effects in terms of exercise, eating, lifestyle, and also other nationalities. This so far has been on a Japanese population. So as we look at the larger studies, where ROC continues to improve, the BDI level, you can see greater than 18 has 100% specificity, so anyone with a score over 18 is agreed upon to be diagnosed as being a major depressive disorder. However, it only captures 40% of the population, so it's not very sensitive. The PEA method less than 1.5, 92% of the patients that have low levels, in fact, are diagnosed as major depressive. And we're picking up 94% of the patients. So at this point, the large-scale validations have started in two clinics in Japan, and that'll probably be another year or more of studies. Oh yeah, much better. At this point, again, looking at a clinical plan, I'm not going to go through this, but this is what will evolve over the next year as to how best to use this measurement in terms of looking at remission in major depressive order, looking at bipolar patients, schizophrenia, and also developing just the correct limits of diagnosis. In terms of the biochemistry, or why PEA might be low in these depressive patients, a couple of observations in looking at the patients that were treated with various drugs. Patients with high anxiety being treated with Paxil, Prozac, we find that PEA actually decreases in those treated patients, whereas patients treated with Effexor that have been for depression, the PEA, as you've seen, increases with treatment. And just the cartoon just stating the obvious that depression is a very complicated disease with many neurotransmitters and pathways involved. So how could PEA be involved in those pathways? In one aspect, PEA is a phospholipid metabolism involved in membrane biosynthesis. It's highly available in brain, under young brain, developing brain, under neural proliferation. It also has structural similarities to neurotransmitters such as GABA. Though it's not active in the GABA binding site, in fact, has activity in GABA A-B site, which is associated with other mental diseases. It also is active in this link to reward pathway with the molecule phosphoenanimide, which is this enanimide is over here. So it's a link between ethanolamine and arachidonic acid. So this particular molecule, when dephosphorated, becomes active and goes into the receptor of reward receptor pathway. However, if it hydrolyzes, it releases EAP, and which can make its way into the periphery. And it's highly abundant in the brain. This is a dated reference, but it was also noted in this study that PEA levels were mostly down in the two areas of the brain associated with Alzheimer's. So the point here is that PEA is associated both with neural activity as well as membrane synthesis. A quick note into another developing biomarker in our pipeline related to diabetic or kidney disease. In this case, we're looking again small cohorts to start out with. All these are diabetics, but here's with no kidney disease here, with very low URAC scores. This is albumin to creatinine ratio, and very high filtration rate, compared to patients that have just the opposite, a lot of kidney disease with very high albumin and low filtration rate, and then a cohort in between. So again, starts out just like before. We do an analysis of serum, looking at relative metabolites, comparing them with various statistical measurements to the clinical measurements. Here we're using a more sophisticated algorithm to look at, because we're getting multiple metabolites to separate out the different cohorts. Each of these dots is a patient. Each dot represents a 5 metabolite panel that separates out the patients with the severe liver disease and those kidney disease and those without. And this is the in-between patients over here, less resolution. And this just shows how you can take the metabolites and you can compare them to each of the different cohorts, as well as compare them to the different measurements of the albumin or the filtration rate. So this is a developing program as it continues. At this point, we have 2 RLCs, one based on 5 metabolites with 2 unknowns, giving a very high separation, and that with still a good separation using unknowns. So at this point, we're identifying these 2 metabolites and identifying or developing quantitative assay or panels for these, and then looking at additional patient populations. So the conclusion is biomarker discovery and validation is a pipeline. It starts with accurate quantitative data, increasing group size and additional controls, requires assay development. It can develop with a single analyte such as PEA or multiple analytes. At this point, then we look at biological and pathway analysis, and as well as developing a clinical plan, which might be an algorithm based on combination of clinical measurements as well as blood metabolites. And that's the end of my talk, and I want to thank Dr. Kawamura for he was the lead investigator for the major depressive disorder study. And that's my talk. Your dad's back.